New York, 1952. The air in the cancer wards was thick with the scent of antiseptic, despair, and the metallic tang of fear. For patients diagnosed with cancer, the prognosis was often a whispered death sentence, a grim countdown. Medical science offered limited solace, brutal, disfiguring surgeries that often failed to remove all malignant cells, or radiation therapy so indiscriminate it scorched healthy tissue alongside the diseased. Early attempts at chemotherapy involved single, highly toxic drugs, often derived from mustard gas, which yielded fleeting remissions at best and devastating side effects at worst. The prevailing medical philosophy was one of brute force, a desperate gamble against an implacable foe. Cancer's shadow loomed large, a terrifying unknown. Into this landscape of medical futility, a young, brilliant black oncologist stepped forward, her mind alight with a revolutionary concept. Dr. Jane Cooke Wright, barely in her early 30s, dared to challenge the orthodoxy. Her family lineage was steeped in medical innovation. Her grandfather, Dr. C.C. Cooke, was one of the first black graduates of Yale Medical School, and her father, Dr. Lewis T. Wright, was a pioneering surgeon and cancer researcher who not only fought for racial equality in medicine, but also developed innovative surgical techniques and was the first African American appointed to a surgical staff at a non-segregated hospital in New York City. Jane had absorbed this spirit of relentless inquiry and social justice from birth. She saw the limitations of single-drug approaches, understanding intuitively that cancer, a complex, multifaceted disease, required a multi-pronged assault. Her radical idea was simple, yet profoundly complex for its time. Combine multiple chemotherapy drugs, not just one, to attack cancer cells from several angles simultaneously. This synergistic approach, she hypothesized, could overwhelm the cancer, reduce the likelihood of drug resistance, and potentially lower the individual toxicity of each agent when administered in smaller, targeted doses within a regimen. The scientific community, predominantly white and male, met her proposal with immediate and palpable skepticism. The prevailing wisdom dictated a one-drug, one-target approach, largely due to a nascent understanding of pharmacology and a deep-seated fear of compounding toxicity. The idea of deliberately introducing potent chemicals into an already weakened patient was viewed with extreme caution, if not outright alarm. Furthermore, the notion that a young black woman operating within a medical establishment rife with racial segregation and gender discrimination was almost unfathomable to many. Dr. Wright worked at Harlem Hospital, a predominantly black institution, a bastion of excellence often overlooked by the mainstream medical establishment. This isolation, while fostering a unique environment for black doctors to thrive, also meant that groundbreaking work conducted there often struggled to gain recognition, funding, or even serious consideration from prestigious, predominantly white institutions. Her vision was not just a scientific challenge, it was a social and professional insurgency. Imagine the hushed, condescending tones in conference rooms, the dismissive hand waves from senior male colleagues who had spent decades clinging to established practices. Too complex, they might have murmured. Too dangerous. Unproven. The weight of systemic prejudice was not merely an abstract concept, it was a tangible barrier, a thick glass ceiling reinforced by generations of institutional bias. For a black woman in the 1950s, simply gaining access to the necessary resources, laboratory space, funding, and patient cohorts for clinical trials was an uphill battle. To then propose a therapeutic revolution was an act of audacious defiance. Her father, a stalwart advocate for her talent, provided an invaluable sanctuary and mentorship, allowing her initial research to flourish within the walls of Harlem Hospital. But outside, the medical world was slow to listen, quick to judge, and quicker still to dismiss. The emotional stakes were impossibly high. For Dr. Wright, it wasn't merely an academic exercise. It was a crusade, fueled by the faces of suffering patients, by the memory of her own father's battle with cancer, and by an unshakable belief in the power of scientific inquiry to alleviate human suffering. She understood that every moment of delay, every dismissal of her ideas, translated into more lives lost, more families shattered. Would her unconventional, profoundly empathetic approach prove to be the breakthrough cancer desperately needed, a beacon of hope in the suffocating darkness of disease? Or would it be relegated to the margins, dismissed as too audacious for its time, and, more pointedly, too audacious for? The answer lay not just in the science, but in the willingness of a prejudiced world to truly see and acknowledge genius, regardless of its packaging. The stage was set for a confrontation between groundbreaking innovation and entrenched bias, a battle that would define the future of cancer treatment, yet leave her name largely unwritten in its earliest chapters. Following that audacious proposal and the immediate skepticism it generated, Dr. Wright did not retreat. She doubled down, transforming her radical hypothesis into meticulously gathered, undeniable proof. She understood that in the face of ingrained prejudice, her data would have to speak not just loudly, but irrefutably. Her laboratory at Harlem Hospital became a crucible of innovation, a place where the future of oncology was being forged brick by painstaking brick. Dr. Wright pioneered a revolutionary technique for her era, testing of chemotherapy drugs directly on patient tissue samples. This wasn't merely a theoretical exercise, it was a pragmatic, ethical, and predictive leap forward. Instead of subjecting patients to a battery of toxic drugs through trial and error, a common, often devastating practice at the time, she would take biopsies of their tumors, grow these cancer cells in culture, and then expose them to various single and combination chemotherapy agents in the lab. In vitro testing allowed her to observe, in a controlled environment, which drugs or drug combinations were most effective at destroying a patient's specific cancer cells, minimizing harm and maximizing the potential for success before a single dose was administered to the living patient. The technical challenges of this endeavor in the 1950s cannot be overstated. Cell culture techniques were nascent, contamination was a constant threat, and the precise measurement of drug efficacy required an extraordinary degree of skill, patience, and meticulousness. Yet, Dr. Wright, often working long hours with limited resources, perfected these methods. From these crucial, groundbreaking experiments emerged successful clinical trials involving her combination therapies. She didn't just find combination, she systematically identified optimal drug pairings and sequences for a range of cancers, including breast cancer, leukemia, lymphoma, and melanoma. Her findings, detailing unprecedented remission rates and extended survival times for patients who had previously been given no hope, began to appear in leading academic journals such as and. These were not anecdotal observations, they were rigorous, peer-reviewed scientific publications, complete with detailed methodologies, statistical analyses, and patient outcomes that demonstrably outperformed existing treatments. Her irrefutable data was a direct challenge to the medical establishment, a testament to her genius and the efficacy of her approach. Yet, even with this overwhelming scientific evidence, the systemic barriers she faced were relentless. Funding for her cutting-edge research remained scarce, a constant, demoralizing struggle. Despite the relentless, systemic attempts to obscure her light and diminish her contributions, the sheer force and undeniable efficacy of Dr. Jane Cooke Wright's science could not be contained forever. Her methodologies, the strategic deployment of combination chemotherapy, and the predictive power of drug testing were too effective, too life-saving to be ignored indefinitely. As more patients experienced profound remissions and extended lifespans, the medical community, however reluctantly, began to adopt her protocols. Her work sparked a revolution, transforming cancer from an almost universally fatal diagnosis into a manageable and often curable disease for millions. The shift was gradual but inexorable, built on the solid foundation of her meticulous research. Oncologists began to understand that targeting cancer with a multi-drug approach was not just viable but superior, leading to better outcomes and reduced drug resistance. From that initial skepticism, her approach became the bedrock, the very operating system of modern oncology. Dr. Wright wasn't merely a brilliant researcher, she was also an extraordinary leader and advocate. Her intellectual prowess and unwavering dedication propelled her to unprecedented heights for a Black woman in medicine during her era. In 1967, she was appointed Associate Dean and Professor of Surgery at New York Medical College, becoming not only the highest-ranking African-American woman in medicine at that time, but also a pivotal figure in shaping medical education and research. She was also a founding member of the American Society of Clinical Oncology in 1964, a testament to her standing among her peers, even as broader public recognition lagged. Through these roles, she continued to champion innovative cancer therapies, advocate for greater diversity in medicine, and mentor countless students, particularly women and minorities, inspiring them to pursue careers in scientific research. Her influence extended globally. She served on the President's Commission on Heart Disease, Cancer, and Stroke, and was a delegate to the World Health Organization, sharing her expertise and shaping global health policy. Today's standard chemotherapy protocols, from the multi-drug regimens used to treat aggressive leukemias and lymphomas to the adjuvant therapies that have revolutionized breast and colorectal cancer treatment, directly descend from the principles Dr. Wright pioneered. The very concept of personalized medicine in oncology, where treatments are tailored to an individual's specific tumor biology, has its roots in her early testing, which sought to predict drug response on a patient-by-patient basis. Modern oncology owes its very existence, its fundamental approach to combating cancer, to her foresight, courage, and intellectual brilliance. Millions of lives have been saved, countless years added to human existence, and untold suffering alleviated because Jane Cooke Wright dared to think differently and had the tenacity to prove her theories. Every patient who receives a combination chemotherapy infusion today is, in essence, benefiting directly from her erased legacy. While her techniques were adopted globally and her methods became standard practice, widespread recognition of Jane Cooke Wright as the primary architect of modern chemotherapy remains an ongoing, infuriating fight. Her name is still largely absent from mainstream historical accounts of cancer breakthroughs, often overshadowed by male colleagues who built upon her foundations. This systematic omission is not accidental. It is a consequence of the very institutional biases she fought against throughout her career. A reminder of how deeply entrenched prejudice can be, even in the supposedly objective realm of science. Her story isn't just about a scientific cure, it's a stark, painful reminder of the immense human genius lost, delayed, and minimized when racial and gender prejudice dictate who gets to lead, who gets to be heard, and whose achievements are deemed worthy of historical remembrance. The cost of such erasure is immeasurable, not just to the individual scientist, but to the collective progress of humanity. For how many other cures, how many other societal advancements have been delayed or entirely missed because brilliant minds were systematically pushed to the margins? Restoring Dr. Jane Cooke Wright to her rightful place in medical history is not merely an act of historical correction. It is an imperative, a reassertion of truth, and a powerful inspiration for future generations of innovators, reminding us why remembering truly matters. Her legacy is a beacon, illuminating the path forward while simultaneously casting a critical light on the shadows of the past, urging us to ensure that such injustice never again obscures the light of human ingenuity. The cost of such erasure is immeasurable, not just to the individual scientist, but to the collective progress of humanity. For how many other cures, how many other societal advancements have been delayed or entirely missed because brilliant minds were systematically pushed to the margins? Restoring Dr. Jane Cooke Wright to her rightful place in medical history is not merely an act of historical correction. It is an imperative, a reassertion of truth, and a powerful inspiration for future generations of innovators, reminding us why remembering truly matters. Her legacy is a beacon, illuminating the path forward while simultaneously casting a critical light on the shadows of the past, urging us to ensure that such injustice never again obscures the light of human ingenuity.